Flial chest usually occurs when 3 or more adjacent ribs are fractured at 2 or more sides. So the adjacent ribs, okay, for example the third, fourth and fifth ribs, okay, if there is fracture in the third, fourth and fifth ribs, then it is known as the flial chest, resulting in the free floating rib segments. Okay, the area of the ribs will be free floating. This produces paradoxical chest wall movement in the flial segment. So we know that when we breathe in, our lungs will expand, the chest will expand, and when we breathe out, the chest will compress. Okay, the chest will compress. So in this paradoxical chest wall movement, it will be the opposite. Okay, when we breathe in, the chest wall will be compressed, and when we breathe out, the chest wall will be expanded. So this shows the this is the characteristic of the flial chest. That means there will be severe respiratory distress. There is associated respiratory distress from the paradoxical chest wall movement associated with pulmonary contusion and painful rib fractures causing the voluntary and involuntary chest splinting. Okay, so also there will be pain along with the paradoxical chest wall movement, and also there will be involuntary and voluntary chest splinting. So the chest will be very rigid and it will not be able to move properly. In the pathophysiology, flial chest injury and breathing in paradoxical manner. So we all know paradoxical manner, the opposite of what we normally breathe. Then increased dead space, reduction in alveolar ventilation, and decreased compliance. So there will be in the oxygenation, and during the inhalation and exhalation there will be reduction in the alveolar ventilation. That means the alveolar will not be able to receive the normal amount of oxygen that a normal person will be receiving. So there will be retained airway secretion and atelectasis, hypoxemia, and if gas exchange is greatly compromised, then respiratory acidosis will be the result of carbon dioxide retention. So when the airway secretions are retained inside the lungs and the gas exchange is not done properly, what will happen? Respiratory acidosis will be there. Respiratory acidosis means there will be the carbon dioxide which is to be exhaled outside will not be exhaled. Okay, it will remain inside the lungs. Okay, then due to the increased amount of carbon dioxide inside the lungs, the acidity will be increased. There will be acidosis. That means the pH of the blood will be decreased. That causes the acidosis. Okay, that means the acidosis. When the pH is decreased, it is known as acidosis. So there will be, if there is large amount of carbon dioxide inside the blood, then it will cause a respiratory acidosis, and it will result in the gas exchange will not be done properly. Then in the clinical manifestations, we have the rapid or shallow respiration, tachycardia will be there. Then movement of the thorax is asymmetric and uncoordinated. Asymmetric thorax will be there during inspection. Then during the inspiration, the affected portion is sucked in. During inspiration, it is bowled out. So we have already discussed paradoxical manner of the chest wall. Okay, so this is the thing. Then chest pain will be there, breathing difficulties will be there. In the diagnosis, we'll do the physical examination, abnormal respiratory movements, x-rays, CT scan, chest x-rays will do, then CT scan, chest will do, then ABG analysis will be done. Under the medical management, the first thing we have to do is always to give the airway management. In the patient with respiratory problem, we have to first, what we'll do first is to always provide the airway management with the help of oxygen or with the help of ventilation. Then we'll do the administration of IV fluids. Then pain management will be done, mechanical ventilation can be given, then secretion will be cleared from the lungs through the suctioning, and pulmonary physiotherapy should be done. But in rare circumstances, surgery may also be required. Regardless of the type of treatment, the patient is fully monitored by serial chest x-rays, ABC analysis, pulse rate, and bedside pulmonary function monitoring. So, even if the patient is under treatment, the patient should be repeatedly taken the chest x-rays of the patient, ABC analysis, pulse rate, and pulmonary function monitoring should be done repeatedly. Okay, so this is all about the Flial chest. Next is the pulmonary contusion. So this pulmonary contusion, it is the most common thoracic injury. Then it is associated with Flial chest, defined as damage to the lung tissues resulting in hemorrhage and localized edema, characterized by development of infiltrates and various degree of respiratory dysfunction. Okay, so this is associated with this will be associated. Pulmonary contusion will be associated with the Flial chest, or it is defined as the damage to the lung tissues, okay, resulting in hemorrhage and localized edema. So pulmonary contusion is a bruise of the lungs caused by the chest trauma. Okay, as a result, damage to the capillaries, blood, and other fluids accumulated in the lung tissue. So when there is a bruise of the lungs caused by the chest trauma, it will cause the damage of the capillaries and other fluids in the lungs tissue. So if there is damage in the lungs tissue, then there will be no it will interfere with the gases exchange, and it will potentially lead to the inadequate oxygen levels. That means hypoxia will be occurred. The pathophysiology, due to the injury to the lungs parenchyma and its capillary network, it will result in the leakage of serum protein and plasma. Okay, then due to this, the abnormal accumulation of fluid in the interstitial and intra-alveolar space will be there. So when there is a injury to the lungs parenchyma and the capillary network, what will happen? Serum, protein, plasma, the protein and plasmas which are present inside our blood, inside the capillaries, these are all leaked. Then what will happen? This will accumulate inside the intra-alveolar space, between the space between one alveoli to the another alveoli. It will get accumulated. Okay, this fluid exerts osmotic pressure that enhances the loss of fluids from the capillaries. So this fluid which are present in the intra-alveolar space, it will exert an osmotic pressure, okay, then enhance the loss of fluids from the capillaries. So in the osmotic, you see osmotic pressure. That means the fluid which is present inside the lungs, it will exert an osmotic pressure. That means it will not allow the fluid that is present inside the lungs to get back to the blood. It will create more pressure to to increase the passage of the proteins and plasma from the blood inside the lungs only. So it will create a pressure which will allow more loss of the fluids from the capillaries. Instead of making up the loss, it will enhance more loss from the capillaries. Okay, then what will happen? Blood and cellular debris will be formed. That means that dead cells of the blood and cells will be formed and inside the lungs, and it will be accumulated in the bronchioles and the alveoli. Okay, then if the bronchial if it is accumulated with the dead cells, the bronchioles and alveoli, it is a main passage of the gases exchange. Okay, so if it is blocked by the dead cells and debris, what will happen? It will interfere with the gas exchange. The normal passage of the oxygen and carbon dioxide will not be able to move properly. Then as a result, the patient will be having hypoxemia and carbon dioxide retention. There will be loss of oxygen inside the blood, and also carbon dioxide will be retained inside the lungs. So it will cause the symptoms of pulmonary contusion. So let's see what are the symptoms. The symptoms are decreased breath sounds, tachypnea, tachycardia, chest pain, hypoxemia. This all we all know this. Okay, what are the meaning? Tachypnea means there will be increased respiratory rate. Tachycardia, increased heart rate. Then chest pain will be there. Hypoxemia, that means a low level of oxygen will be there in the blood. Then blood thin secretions and respiratory acidosis will be there. Okay, then secretion will come along with the blood, and then respiratory acidosis will be there. Then large amount of mucus, and the patient will produce large amount of mucus and constant cough, but the person cannot clear the secretions properly. They may have signs and symptoms of AR, upper respiratory disorders. Okay, acute respiratory distress syndrome. Then in the diagnosis, physical examination, chest x-ray, CT scan, same. Okay, then medical management will give the supportive treatment until the pulmonary contusion resolves. Will do fluid restriction. Okay, because here in this case, if the patient has more fluid, then it will be accumulated more inside the lungs, so we have to restrict the fluid in order to decrease the secretion. Then postural drainage may be done. Physiotherapy will be done to remove the secretions. Then pain management, antibiotic therapy, and supplementary oxygen will be given. Then bronchoscopy may be required to remove the secretions. If we are not able to remove the secretions normally through the suctioning, then bronchoscopy might be required with the help of the bronchoscopy. Then diuretics will be given to reduce the edema. Edema will be occur inside the lungs, so diuretics may be given to reduce that edema. The nasogastric tube to relieve the gastrointestinal distension, so NG tube may be given to the patient. Then in severe cases, intubation will be done and ventilatory support will be necessary. Then colloids and crystalloid solution may be used to treat the hypovolemia. Okay, so these all are the so you see, these are the medical management of the pulmonary contusion.